Hi, very good morning. Now we are showing you again another person with 8.5 syndrome. Now you can see here the person is asked to look straight. You can see nasolabial fold very nicely here. Nasolabial fold is not present. Angle is drooping. Angle is drooping. And if you see the position of the eyeball on the right side and see the position of the eyeball here, it is little bit adducted. Little adducted. Right? Now it's last to concentrate on this finger. You can see the position of this eyeball and see the position of this eyeball. Right? Now when he's concentrating on that, you can just observe what is happening. Now this is movement to the right side. Complete abduction, adduction possible. Now when he's asked to look to the left side, you can see this eyeball. Just follow that eyeball. This cannot abduct. Now you can see here, this eyelid is closing and this cannot close completely. Is asked to look up, upward gaze is present. Asked to look down, downward gaze is present. Is asked to converge, there is convergence. And now you can see here, this eyelid is closing nicely, this eyelid remains open. You are asking to look up. See when he is closing the eye, this nasolabial fold is clear, this is lifted up, this is drooping down. There is no nasolabial fold at all. And see the closure. This is tightly closed, this is not tightly closed. Now if you try to open, easily you can open it. And opposite side, difficult to open against resistance. You can see this angle is opening when it's lifting up, but this is drooping down. This is this side facial, so we call left side facial, left side abductor gone, left side gaze is also affected. So 7 plus 1.5, so we call 8.5 syndrome. Now you can see this here, this is vertical gaze. Now there is no vertical eye movement, you can see clearly. Little downward movement is there. Here vertical movement is not clear. Person is asked to converge. See, vertical eye movement is almost absent. This is downward gaze. When you are doing this particular indirectly, you are doing doll's eye movement. Now person is asked to look up. Little movement is present. This is when you are asking to look to the right. You can see clearly this eye is abducting, this is adducting. So horizontal gaze is present. You are asking to look down and out on the right side. You can see this eyeball is moving, this is also moving. This is look laterally. Now this is in upward field. Difficult. Now you are asking to look to the left. You can see here the movement is poor. See, it is not complete. You can see this is also not adducting properly. This is also not abducting. Now you can see that is abducted. This is adducted but not complete. This is what is called as a vertical gaze palsy. Now this is a very nice lecture by Vishal Pawar. You can just listen to that. This is internuclear ophthalmoplegia. This is right eye, this is left eye. When there is a damage to medial longitudinal fascicle, you get an internuclear ophthalmoplegia. See, the right eye is showing you abductor squint and nystagmus, and left eye cannot adduct. So there is a paresis of adducting eye, and in the right eye, which is abducting, you get a nystagmus. Plus, you have got absence of adduction. This will be because of involvement of medial longitudinal fascicle. And this particular nystagmus is because of visual error signaling to overcome the adducting weakness of the fellow eye. There is a paresis of adducting eye. This is very typical of what we call the internuclear ophthalmoplegia. This is third cranial nerve. This is the sixth cranial nerve. And this yellow line which is showing you is a medial longitudinal fascicle. And if you divide, anterior medial longitudinal fascicle is in midbrain portion and posterior is in a pontine portion. So you can divide into anterior and posterior. Now, if you get the damage to anterior, midbrain convergence is involved. Midbrain portion is involved because convergence center is close to midbrain. While in a posterior, because that center is not in pons, you get convergence pair. So if you get an INO with convergence present, then it is lesion in, means in a posterior INO, convergence will be spared. And if convergence is involved, then it is more in favor of an anterior INO, means in upper part of midbrain. In upper part of midbrain. Because convergence is because of what we call as the convergence center, which is present in a midbrain. This is pons cut section. This is 6 cranial nerve nucleus. This is parapontine reticular formation. This is eye center in a frontal lobe. So left side will be innervated by the right frontal eye field. You can see how it is innervated. It is innervating the opposite side parapontine reticular formation, which will supply to 6 cranial nerve. That 6 cranial nerve will supply same side 6 cranial nerve, that is abducent, and it is going to supply opposite side third cranial nerve via medial longitudinal fascicle. We call as a right side medial longitudinal fascicle, which will supply right third cranial nerve, which will supply medial rectus, which will produce adduction, and this 6 cranial nerve will stimulate lateral rectus, which will produce abduction of the left eye, and this will produce adduction of right eye, and this will be responsible for what we call as a left gaze, left side gaze. So right frontal field will be stimulating left side parapontine reticular formation. You can see this. There is a abduction of the left eye, adduction of the right eye. Now if you get the damage here, that is PPRF and left side medial longitudinal fascicle, this is the posterior part of the pons. So if you get a damage here, you will have a gaze palsy with even what we call as internuclear ophthalmoplegia, and then we call that as 1.5 syndrome. Or you can have involvement of 3 structures, abducent nerve, PPRF, that is parapontine reticular formation, and left medial longitudinal fascicle, and that can produce 1.5 syndrome. So what are the components of 1.5 syndrome will be shown here. So when you ask the person to look to the left, conjugate horizontal gaze palsy will be there, means the left eye will not be able to abduct and right eye will not be able to adduct. Plus you will have an involvement of the left medial fascicle. That means when you are asking the person to look to the right side, left eye cannot adduct. You can see that now. The right eye will abduct, and during that abduction there will be nystagmus. You can see that there will be nystagmus. Vertical movement will be preserved, convergence will be preserved, because this is a pontine lesion. Convergence center is present in the midbrain level, that is prefrontal nucleus, in that area, or we call as junction of the thalamus and mesencephalic. It is also called as a thalamo-mesencephalic junction at that level. So vertical movement is at that level, and convergence is because of the prefrontal nucleus. So that is preserved, or we call spared. So this will be very characteristic. You will have a right abductor nystagmus. You can have a right eye abduction possible. Left eye adduction will be absent, and there will be total involvement of a left side gaze palsy, meaning left eye cannot abduct and right eye cannot adduct. This is called 1.5 syndrome. This was described by Fisher. 1 means complete absence of gaze palsy, and half, that is abduction is possible but left eye cannot adduct. So that is half. That's why it is called 1.5. Very common etiology, infarction and demyelination. Demyelination, classical example, multiple sclerosis. And when this is involved along with what we call as a 7th cranial nerve palsy, then we call that as 8.5. 1.5 plus 7. So